Hello everyone, this is Dr. Humanist again. Let us now discuss about hemolytic anemia. Okay, mainly we'll be discussing about the classification and briefly about the diagnosis and the treatment. Right. So first classification is based on intrinsic or extrinsic lysis of the RBCs. Okay. What does intrinsic hemolytic anemia mean? There is some problem within the RBC causing its destruction. Okay, so intrinsic defects within the RBCs and they are usually inherited. Okay, we'll see the examples. First one is because of the membrane defects. Okay, membrane of the RBCs, mainly the proteins like ankyrin and spectrin. Okay, abnormalities in that will lead to its disruption. What are the examples? Hereditary spherocytosis and hereditary erythrocytosis. Okay. Next is enzyme deficiencies. Right, examples are G6PD deficiency, right, and pyruvate kinase deficiency. Okay, so how it will lead to destruction of RBCs is because of the oxidative stress. So whenever there is oxidative stress in the body and there is no enzyme to protect it from the oxidative stress, like that is G6PD, because of that there will be lysis of RBCs. Next is hemoglobinopathies. Some problem in the hemoglobin structure itself or in the synthesis of it. Examples are sickle cell disease and thalassemias. Right. So there are three main headings, like one, membrane defect, enzyme defect, and hemoglobin defect. This you have to remember. Next, coming to the extrinsic hemolytic anemia. That means RBCs are normal, but some external factors are causing destruction of RBCs. We'll see what are the causes. First one is immune mediated. So for the example, autoimmune hemolytic anemia, that is AIHA. What happens is these antibodies will target the RBCs antigens and leading to destruction by complement as well as the macrophages in the spleen and the liver. Right, so antibodies will go and attach to the antigens present on the RBCs. It will lead to destruction of it by complement as well as into the spleen, because now they are targeted by the antibodies. Next is autoimmune hemolysis, that is hemolytic disease of the newborn and drug induced. So these are all immune mechanisms. That means what? The autoimmune, our body is attacking the RBCs. Right. Next is mechanical damage. Examples are MAHA, that is microangiopathic hemolytic anemia, and prosthetic heart valves. Okay, how does they break down the RBCs? By causing the physical trauma. Like if you see the prosthetic valve, physically it will lyse the RBCs. Next is infections that we all know, like malaria, babesiosis. Right, they directly go and invade the RBCs and they'll multiply inside the RBCs, and when they come out, they'll lyse the RBCs. That is when you will get high grade fever. Right. Next is toxins. Toxins like snake venom, especially the vasculotoxic snake bites, right? The viper bite, isn't it? Chemicals and severe burns. So these toxins directly damage the RBC membranes. Okay. Next classification is based on either the lysis is happening intravascular or extravascular. Intravascular means inside the blood vessel. Extravascular means what? Inside the reticuloendothelial system, mainly the spleen. Okay. So intravascular hemolysis we'll see first. So destruction of RBCs within the blood vessels, as I said, leading to the release of hemoglobin into the bloodstream. Right. So what are the examples? PNH, that is paroxysmal nocturnal hemoglobinuria. What happens here? Because of the mutation in PIGA gene, the CD55 and CD59 are not able to attach to the RBCs. So they are protective. When they are not there, then the complements will go and attack the RBCs. Right. So protective proteins are lost, CD55 and CD59. Okay. So complement mediated destruction will happen, hemolysis will happen, the hemolyzed blood will go and hemoglobins will go and collect in the bladder, and in the morning patient will have hemoglobinuria. Next is microangiopathic hemolytic anemia. As I discussed just now, it will cause hemolysis inside the blood vessel. Right. Next is TTP, that is thrombotic thrombocytopenic purpura. Even that is a form of microangiopathic hemolytic anemia. Next is HUS, that is hemolytic uremic syndrome, and DIC, disseminated intravascular coagulopathy. So some problem in the blood vessels causing the destruction of the RBCs. Right. Next is the mechanical damage, that is prosthetic valves, infections, malaria, babesiosis, and severe burns, as we discussed now. These all mechanisms will lead to the hemolysis inside the blood vessels and less outside the blood vessel, that is in the spleen. Next is extravascular, we'll discuss. Okay. As I said, destruction outside the blood vessels, predominantly in spleen and liver. What are the causes? Hereditary spherocytosis, autoimmune hemolytic anemia. So both can, autoimmune hemolytic can have inside the blood vessels, outside the, or into the spleen also, mainly in the spleen, because the autoimmunes, the auto antibodies are going and attaching the RBCs. Now the spleen detects it as abnormal RBCs and it will start to lyse it. Next is sickle cell anemia, thalassemia, and in the cases of hypersplenism also. So what happens here is, normal RBC span we all know is 120 days. After that, what happens is, because RBC doesn't contain nucleus to maintain its integrity, the cell membrane and all, it will become sluggish, and spleen will detect this. So RBCs will pass the spleen. Normally it will go fast, it will flow nicely because of the shape of the RBCs. But when the RBCs become sluggish, it will catch hold of the RBCs and it will cause its lysis. So some disorders where the lifespan of the RBCs become less because some problem in the RBC itself, and it will cause its sluggish movement in the spleen, and now spleen will go on breaking down the RBCs continuously at early stages only. So what are the examples? Spherocytosis, where there is a problem in the membrane of the RBCs. Autoimmune hemolytic anemia, where the RBCs are targeted by the autoantibodies. Sickle cell disease, where the sickling of the RBCs, right, itself will cause sluggish movement of the RBCs. And thalassemia, that is a problem in the hemoglobin itself, right, changing its shape and size. Hypersplenism, so spleen is acting more and more. Okay, so how does it happen is, splenic macrophages will go and phagocytize the RBCs. Okay. So next, coming on the, either it is immune mediated damage or non-immune mediated. Immune mediated, as I said, it is because of the immune attack. The examples are autoimmune hemolytic anemia, warm autoimmune hemolytic anemia, that is most common form, right? There are two types, right? Warm antibodies and cold antibodies. Okay, cold antibodies, there is a lysis or activation of the IgM antibodies at the low temperature, that is at the periphery, right? But most commonly, warm antibodies will see in most of the diseases. If you see some infections or even autoimmune disorders, you will get warm autoimmune hemolytic anemia. Whereas in cold autoimmune hemolytic anemia, some examples like in the infection of mycoplasma, right? So because of this, there will be immune mediated damage to the RBCs. Next is hemolytic disease of the newborn, right? It is because of RH incompatibility. Hemolytic transfusion reaction, right? That is immune mediated destruction of RBCs. Drug induced hemolysis. Examples are penicillin, methyl dopa. There are many examples which can lead to drug induced hemolysis. Okay, this you have to remember: warm autoantibodies or cold autoantibodies. Cold are IgM, warm are IgG mediated destruction. Non-hemolytic, so non-immune hemolysis. Examples are MAHA, that is microangiopathic hemolytic anemia, because of TTP, HUS and DIC, G6PD deficiency, infections, toxins, right? So now coming to the brief discussion of the diagnostics. CBC will do, first of all, okay, what will find? The decreased hemoglobin, that is anemia. Reticulocytosis will get, right, because the bone marrow is trying to compensate the lost RBCs. PS smear, what will say? Peripheral blood smear, what you will get? Abnormal RBC shapes like spirocytes in HS, schistocytes in the maha, right? And we'll do direct Coombs test. We'll get positive in autoimmune hemolytic anemia. Okay, next is indirect Coombs test also we can do to detect the free antibodies in the serum. Okay, like if you see in the transfusion reaction and hemolytic disease of the newborn, we'll get free antibodies inside the serum of the patient. Next is LDH. LDH is related by RBCs itself. When there is more lysis, the LDH is released. Next is haptoglobin. Okay, mainly it will decrease. Okay, it will go and bind to the hemoglobin because hemoglobin is very toxic molecule. Okay, haptoglobin has to bind to the free hemoglobin to reduce its toxicity, right? So where you will get one severely reduced haptoglobin in the cases of intravascular hemolysis. But if you see, if there is destruction in spleen, haptoglobin will decrease, but not that significant decrease we will see. So this is one of the method to differentiate if the lysis is happening inside the vessel or into the spleen. Right. Next is unconjugated bilirubin. If you see the RBC breakdown pathway, it will eventually lead to bilirubin formation, right? Biliverdin will be there, and then bilirubin. Then bilirubin will go into conjugation, and then it will be excreted through the bile. This pathway we all know. So when there is a more and more destruction, the liver cannot handle that much of bilirubin, right? So there will be elevation of the unconjugated bilirubin. Then urine hemoglobin will be increased, right? Especially if there is intravascular hemolysis, there will be free hemoglobin. So free hemoglobin in the urine causes the change in the color of the urine. Next is urine hemocytin also. So more and more hemoglobin is there, hemoglobin will bind to each other and will cause hemocytin, right? Next is even splenomegaly we can do. Splenomegaly, as I said, it is more commonly seen in extravascular hemolysis. When the breakdown is happening in the spleen, the splenomegaly will be significant. But intravascular, it will be there, but not that much. Okay. Management, you will see brief discussion. Autoimmune hemolytic anemia, you use first line steroids, second line rituximab, splenectomy, and blood transfusions. Hereditary spherocytosis, folic acid supplementation, splenectomy, and vaccination we have to do. Before splenectomy, like pneumococcal, all capsulated bacteria, pneumococcal, Hemophilus influenza, Neisseria meningitis, these are all vaccination has to be given. G6PD deficiency, you have to avoid the oxidative stressors like fava beans, sulfur drugs, etc. There is a list of sulfur drugs which causes the hemolysis in G6PD deficiency. Okay. The transfusions for severe anemia and hemolysis. Thalassemia, regular transfusions, as we all know. Iron chelation therapy, because of it can have a risk of hemochromatosis, and sickle cell anemia, nothing, hydroxyurea we have to give. It will increase the fetal hemoglobin. Blood transfusions and pain crisis will be there, so we have to manage the pain also. And a PNH, the wonderful drug eculizumab, complement inhibitor, that is C5 inhibitor, right? We have to give once in 2 weeks, right? And blood transfusions, iron therapy. Also we can go with stem cell transplantation. So this was the brief discussion of hemolytic anemia, classification and diagnostic and treatment approach.